I'd like to thank the organizers for the invitation to address you on this beautiful day here in Moscow. It is a tremendous pleasure for me, and it's been quite an eye-opening experience to be able to tour this hospital. It's quite an impressive place. So we're changing the order of the schedule a little bit. I'm switching the order of my talks because I kind of thought, well, you know, if I'm going to talk about intracranial pressure and then fancy brain multimodality monitoring, I probably should start with the basic stuff. And there's probably nothing more basic or essential to the practice of neurocritical care than the monitoring of intracranial pressure. The point of this slide is that ICP is an issue for us because the good Lord found it in His or her wisdom to give us a skull. And that skull's great. It protects our precious, delicate brain from the knocks and the traumas that occur in daily life. The problem, though, is that the cranium is a rigid vault. And there's only so much room in there. This slide illustrates the normal contents of what's in our skull. Most of it, 80%, is brain. Maybe 12% is CSF volume, and another about 12 to 15% is blood. The brain is an extremely vascular organ. Normal intracranial pressure measured with a needle, the upper limit is 20 centimeters of water. But with conventional bedside monitoring systems, when we monitor ICP in millimeters of mercury, or in torr, the upper limit of normal is 15 millimeters of mercury, and that is a standard conversion factor of 1.33. So, at the heart of it, if you want to understand ICP, the first thing we need to realize is that all causes of increased intracranial pressure have to be thought of in some way as a process that increases intracranial volume, because there's a standard relationship of pressure to volume. So, the ICP can go up from a space-occupying lesion, like a subdural hematoma or brain tumor. It can elevate due to increased CSF volume, which is hydrocephalus. It can increase because of processes that engorge the brain with an abnormal increase in cerebral blood volume. And this can occur with a variety of different processes that all involve, at the heart, vasogenic edema. And the brain can swell up itself in an avascular fashion, and that's what happens with cytotoxic edema in the case of brain infarction. As a corollary, anything that reduces intracranial pressure has to be understood as something that reduces intracranial volume. So how do we get ICP down? Well, number one, at the heart of it, we can remove a mass lesion. Call your friend the neurosurgeon. And as I'll tell you later, surgical intervention, whether it's removing a mass lesion or draining CSF volume, is at heart the primary therapy that we think about first, and we always continue to think about when we're managing elevated ICP. We can reduce the cerebral blood volume with hyperventilation, which causes vasoconstriction, and we can reduce it further with deep barbituric anesthesia or with hypothermia. If you think about it, why would pentobarbital lower the ICP in a patient who is already sedated, right? It's got to be reducing some sort of volume. It does so by causing profound metabolic reductions that are then coupled to reductions in cerebral blood flow and volume. That's how pentobarb and hypothermia works. Hypothermia also reduces the blood-brain barrier permeability and can reduce vasogenic edema, leakage of fluid out of the vasculature, And then finally, we can reduce parenchymal brain volume with bolus osmotherapy, generally in the form of mannitol and hypertonic saline. The way that the pressure-volume relationship works is illustrated here. So initially, a standard increase in volume in the compliant part of the curve results in a small increase in ICP. When you're up farther, though, on the pressure-volume curve in states of reduced intracranial compliance, now we see that the same increase in volume here leads to a much higher increase in intracranial pressure. There is a handy way, a simple way that we can assess the state of intracranial compliance at the bedside in a monitored patient. And that is by simple inspection of the ICP waveform. In a normal setting where the ICP is low, the pulse pressure of the ICP waveform is low. What's happening? With every beat of the heart, we know when you go and watch a neurosurgical procedure, the brain pulsates. The brain's pulsating because transient increases in cerebral blood volume. When there's high compliance, that little CBV increase results in a small pressure deflection, but in states of increased compliance, as illustrated here, you see a much higher deflection or higher pulse pressure in the ICP waveform. In addition to these changes in the amplitude of the ICP waveform, as compliance is reduced, there are also changes in the morphology of the waveform itself. Normally, the initial P1 or percussion wave is the highest amplitude. The dicrotic wave is created by closure of the aortic valve and a little wave of back pressure into the intracranial vault. And then there's a tidal wave, which is a third reflection from the systemic circulation. For reasons that we don't entirely understand, as the compliance goes down, the P2, as illustrated here, now becomes higher in amplitude in the P1. I think of this as a sort of a stacking effect, that this aortic valve closure then rebounds and reflects, and the pressure in the intracranial vault hasn't had time yet to fall back down before the next little volume bolus or effect, if you will, comes in, and you get this stacking effect. Now, another important principle in terms of managing states of elevated intracranial pressure has to do with understanding the relationship between the mean arterial pressure, or the CPP, and the ICP in states of reduced intracranial compliance. States of reduced intracranial compliance can be easily recognized when patients have reduced level of consciousness and the CT scan shows intracranial mass effect. So ordinarily, and we recognize this is cerebral blood flow. So everybody knows this from your textbooks, right, from when you were in your medical school or nursing school or whatever. And we understand what's going on. As blood pressure falls, you maintain a stable level of cerebral blood flow because there's vasodilation, right? Now, if you're thinking about ICP, normally, with normal intracranial compliance, the ICP is going to stay normal, 5 to 10 centimeters of water, whether you're hypotensive or hypertensive. But when your brain is tight, when your skull is tight, and you have reduced intracranial compliance, there's a relationship that occurs that changes. As blood pressure falls, when compliance is reduced, this additional cerebral blood volume increase cannot be accommodated. And this further drives up the intracranial pressure, as illustrated here, and we call this vasodilatory cascade physiology. So drops in blood pressure lead to vasodilation, and that drives the ICP up. On the other hand, as illustrated on the right, sometimes extreme levels of hypertension can passively expand and dilate the delicate cerebral vascular system on the basis of hydrostatic forces alone. And you can get what we think of as perfusion pressure breakthrough physiology. So you get a passive secondary increase in cerebral blood volume driven by high blood pressure, high MAP, and that drives the ICP up this way. The principle is that in these states of abnormal extremes of blood pressure, we can normalize the ICP here by getting the MAP up and getting here into the happy zone. And here with extreme hypertension, we can sometimes control ICP by lowering the MAP, mean arterial pressure, and seeing with it a passive parallel increase in CPP, ICP, and mean arterial pressure altogether. So you will hear sometimes about a debate, right? In Lund, Sweden, they believe that most ICP problems result from this physiology, and they say keep the pressures low, keep the MAP low, keep the CPP low, and minimize vasogenic edema through blood-brain barrier disruption. U.S. neurosurgeons that were influenced by a fellow named Sandy Rosner recognize that this happens a lot, and they think that this is usually the problem. Well, the answer is that both camps are correct. Some patients have vasodilatory cascade physiology. Some patients have perfusion pressure breakthrough physiology. Some patients may have this problem on Monday and then this problem later in the same week on Wednesday. And I actually think I've seen some patients, rarely, have both types of physiology in the same brain at the same time. But if you look at that relationship of ICP to the extremes of blood pressure, it reminds us of a very basic principle that we see in outcome studies in general. Whether the disease is trauma, subarachnoid hemorrhage, intracerebral hemorrhage, or ischemic stroke, there's a U-shaped relationship between admission blood pressure and mortality, as shown upper, and between neurologic deterioration, as shown in the lower panels here. These patients with severe brain injury do more worse at the extremes of blood pressure. And it may be that these effects on ICP, which of course then lead to reductions in cerebral perfusion pressure, are part of the explanation for why we see this very consistent effect. Now, you may be fighting with a brain surgeon. I need an ICP monitor. Get an ICP monitor in my patient. And the neurosurgeon says, no, prognosis is very poor, I don't know. But then you win the battle, and the surgeon puts the monitor in. And then he goes, aha, you see, the ICP is normal. The patient didn't need it anyway. And you can smile inwardly because you're smarter than that. And you know, well, it may be normal now, but it doesn't mean it's going to stay normal, because ICP characteristically goes up in waves. And these dangerous waves are called Lundberg A waves or plateau waves, as illustrated here. Now, you know that this is an old slide from an old textbook because it's missing something, right? It's missing the CPP, because now we know that it's really ICP/CPP monitoring. But initially, people were ignoring the CPP, which is calculated as the mean arterial pressure minus the ICP. But the seminal observations were made that you have these A waves, and they're defined as longer ICP elevations with a higher amplitude, so greater than 10 minutes, generally well over 20 millimeters of mercury. And then the same patients get the same physiology in a miniature version, and those are called B waves. So these are briefer, generally 2 to 5 minutes, and the amplitude of the elevation itself is less than 10 millimeters of mercury. These Lundberg waves are vasodilatory cascade physiology in action. That's what they are. They're triggered by drops in blood pressure or sometimes physiologic factors we don't understand. The brain vasodilates, that drives down the CPP, and then the brain says, I'm hungry, feed me more blood. The brain vasodilates some more, that lowers the CPP even more. The brain says, I'm hungry, feed me more, and you get this cycle until the brain is stuck on the plateau, on the flat part, in a vasodilated state. That's why the early observations found that very often plateau waves end with a termination spike. You see that little spike there? What's happening if you're doing concurrent monitoring of MAP is that the body says, okay, this is ridiculous. There's a massive systemic surge in systemic vascular resistance. There's a MAP increase, and that MAP increase helps the blood flow go to the brain, and that vasodilated state relaxes, and you go back to a baseline position, bang, and the ICP falls back down to baseline levels. So this is a patient dying of untreated ICP, and here you see plateau wave elevations that are up to 90 millimeters of mercury. And the way you recognize plateau waves at the bedside is that you get these mirror image reductions in CPP simultaneously. This is how you tell. If you see ICP elevations in isolation without the mirror image reduction in the CPP, these are created not by cerebrovascular events like vasodilation, but passively by usually increases in intrathoracic pressure. So treatable by changing ventilator settings or sedating the patient. They don't have these so-called non-cyclic ICP elevations without the CPP dip are not as dangerous, they're much briefer, they're not sustained, and they don't have the same ominous consequences. Here you see my patient here ends up on his final plateau wave, like final exit. And you see what the problem, right? His plateau waves are going up, and you see the mean arterial pressure is starting to become unstable here from autonomic dysfunction. And now we see these ICP elevations, these plateau waves, but the problem is the MAP is falling. He's having vasocirculatory collapse, and now he ends up stuck here with an ICP of 40 to 60, but he's losing his blood pressure and his CPP is not viable anymore. Who needs an ICP monitor? Well, there are guidelines from trauma, and basically I take those guidelines and I apply it to all the diseases that we treat. I say there are 3 indications for an ICP monitor. Number 1, the patient's in a coma. You can define that as a GCS score of 8 or less, or almost 8. Certainly not following verbal commands, I think, would be a prerequisite. But abnormally reduced level of consciousness. Number 2, there needs to be imaging evidence of an abnormal increase of volume in the skull, what we call intracranial mass effect. This may take the form of an extraaxial mass lesion, hydrocephalus, or swelling of the brain and effacement of the basal cisterns, or midline shift. And then the third one, which is important, is that, so now you've got a guy in a coma, and the scan's telling you that you got to worry about ICP. It may be high, it may not. And number 3 is the prognosis of the patient is such that aggressive intensive care is warranted. So in other words, it's worth really trying to give the patient a shot. The way I think of it is, if I've got somebody with a terrible brain hemorrhage in a coma, and they're going to be in the ICU and life support anyway for an early trial of intervention, and I'm worried about the ICP being high, we might as well measure it. I can tell you in the United States, ICP monitoring is well documented to be underutilized. The main reason for underutilization of ICP monitoring is therapeutic nihilism. right? The caregivers, the neurosurgeon, whoever says, well, you know what, you're so badly injured that I don't really think that anything we do is going to help anyway. And we've come to realize now that therapeutic nihilism is an excellent way to reinforce your concepts, because if you never try to help someone and you're convinced you're going to die and they always end up doing terribly and then you withdraw life support and they die, then you're always right and you keep doing that. But what we've come to understand now with neurocritical care is that if you give patients a real bona fide chance, you may say to the family, they're fighting very long odds and the odds are against them. Maybe there's a chance. Well, once in a while, it turns out that the patient surprises you and does better than you'd expect. And that's one of the big lessons in neurocritical care. Some people will say, well, we're not going to put an ICP monitor in. We'll just give mannitol on a regular basis, and I'll hyperventilate them. That's the treatment anyway, right? Well, that approach, I think, is ridiculous. That would be like seeing a patient with decompensated heart failure and retinal hemorrhages who you know has out-of-control malignant hypertension. No one would ever say, oh, here's some blood pressure medicine, just take that. No, you'd put a cuff on, you'd measure the pressure, you'd give treatment, and you'd want to find out if the treatment you're giving is not enough, just right, or too much. And you titrate your treatment to measurements of the blood pressure. So now we have people coming in with life, right on the edge of life and death, with their very being, with a brain injury, with pressure problems in the brain. Of course you want to measure the pressure. But to measure the pressure, you need to do it invasively. There are no reliable clinical signs that are going to tell you what anybody's ICP is, period. The other thing that's important to remember is that the signs that are dramatic that we tend to follow, because the nonspecific signs of high ICP is simply depressed level of consciousness and occasionally vomiting. But these other signs that we see in the ICU, blown pupil, motor posturing, lower extremity rigidity, hyperventilation, and other autonomic changes, are not strictly the consequence of ICP going up. They're the consequence of brain tissue shifts, which result from ICP gradients, from subfalcine herniation or from downward transtentorial herniation. But the treatments that we use to lower a global ICP monitor can also reduce these ICP gradients and effectively arrest or reverse these herniation syndromes. And we use these treatments in the neuro-ICU every day. How do you measure intracranial pressure? Well, historically, the first method is still the gold standard. And that's actually your good old friend, the external ventricular drain or the ventricular catheter. It's simply a catheter that's stiff, that contains the CSF that's connected to fluid-filled tubing to a pressure transducer that's placed at the foramen of Monroe, or close enough, sometimes we'll say ear level, right? That's actually the device that Lundberg used in the 1950s in Lund, Sweden, when he wrote his classic descriptions of ICP monitoring and the A waves and the B waves. The other technology that we use these days are these parenchymal catheters, as illustrated here. And there are actually very many systems available now. Codman, Integra. There's a German company now called Raumedic. There's the Spielberger device. More and more. In the U.S., we have many systems now. But they employ a variety of different types of sensor systems, but they have all been validated against the ventric. The old Richmond bolt was simply a hollow bolt connected to fluid-filled tubing. No one uses that anymore, certainly in the U.S. And the epidural monitors are also not used much because they're slipped in under the bone, but in the epidural space, and because of air in there, they don't give a good fidelity ICP measurements. There's too much drift and the like. So you got your monitor in, and you're going to write your orders. So what are your basic goals? Well, most ICP literature happens to come from the TBI literature, and these guidelines for the management of severe traumatic brain injury say that you should keep the ICP below 20, and you should try to maintain the cerebral perfusion pressure at a minimum of 60, but not much more than that either. And where does this come from? Well, multiple observational studies have shown that 20 is a good cut point. In other words, the more time over 20, right, the larger magnitude above 20 millimeters of mercury for the longer amount of time, people really do worse. They're more likely to die. They're more likely to suffer from poor recovery. And likewise with CPP thresholds, 50, 40, 30, the more you're down at those levels, the worse you're going to do. So you're writing your orders, and there are also general housekeeping orders that we advocate that you write for everybody that's in a unit that has ICP active problems, is at risk to develop ICP problems. What are they? Number one, head of bed at 30 degrees, okay? And you can, with a monitor in place, when you do your bedside examination, that's how you can tell the monitor works. You look for the waveform, and then you can lower the head and watch the ICP go up. Number two, use only isotonic fluids. Hypotonic fluids are bad for the injured brain because the water, the free water contained in hypotonic fluids is going to enter the body and find and flow down any osmotic gradient it can find. Distributes diffusely free water throughout the intracellular and extracellular compartment. In a brain injury, the brain tissue is damaged and ripped up, and there's accumulation of osmotically active molecules, proteins, cellular fragments, and the like, and that creates the osmotic gradient. If you give free water, then that injured brain is going to swell up like putting a dry sponge into a bucket of water. Fever control we've heard a lot about, general housekeeping, seizure prophylaxis we maybe talk about a little more later, but my feeling is if I'm worried about ICP, I don't want to put up with a convulsive seizure. And then another message that we heard quickly before, but in American practice 20 years ago was that everybody at risk for ICP got glucocorticoids, dexamethasone, trauma, ischemic stroke, intracerebral hemorrhage. Steroids are not a panacea for ICP. They are used to specifically reduce the lesion volume of brain tumors and for cerebral abscesses. That's their role. So they treat that particular type of vasogenic edema. But glucocorticoids are actually not effective for reducing lesion volume or water content of the brain from the edema produced by trauma or any form of ischemic or hemorrhagic stroke. Now, recently there's been this concept, and I don't know how much it's extended into this part of the world, but in America about 10 or 15 years ago, people said, well, if normal saline is good, then hypertonic saline must be better. And what we're going to do is instead of writing an order for normal saline, we're going to write an order for 3% hypertonic chloride acetate solutions, and we're going to gradually and slowly develop, establish, and maintain a hypernatremic, hyperosmolar environment for the injured brain. Now, in a minute, I'm going to tell you why we've completely abandoned that practice at our center, and it's being abandoned in most centers that I come in contact with these days in North America and Europe. When you're called to the ER with an acute ICP crisis, an emergency, there are the things that we do in unmonitored patients as emergency interventions before we can institute any definitive therapy. And basically, we get the head up to 30, check, make sure we got normal saline fluid resuscitation, give a dose of an osmotic diuretic. Usually U.S. we use mannitol initially. We use a 20% solution. I know that in Russia maybe 15% solutions. But the thing about mannitol is mannitol works best when you give, bang, big doses, real fast. That's how you give mannitol. So we recommend 1 to 1.4 grams per kilogram. I'm a 70-kilogram man. I want 100 grams of mannitol in an 18-gauge vein through an 18-gauge angiocath wide open. So you want that thing shooting into the system, just hanging in wide open. And then you go to CT for definitive intervention. Now, another known fact is that units that have protocols or algorithms that help you manage ICP get better results than units that don't have protocols. And that's true for most of critical care. That's no surprise. You don't want to be reinventing the wheel in the middle of the night when you're dealing with ICP crisis. This is an example of an ICP protocol that the Brain Trauma Foundation gave out as an example of what you could do some number of years ago. Now, I don't know about you, but I'm a pretty simple guy. And as the night hours go on and I'm taking care of more patients, I get simpler and simpler. And I can't deal with this. I can't deal with this. It's too complicated for me. It makes me feel like this guy. I need a solution. I need something simpler. And that's why in our unit we've developed this simple stepwise protocol. And what the protocol is meant to do is to help you organize your thoughts and keep your priorities straight. Number one, when you're encountering a patient with critically elevated ICP, think first and always of definitive surgical intervention. It might start with a ventric drain. It may lead to craniotomy. And if you run up enough steps and you're losing the battle, you can always play the definitive card, hemicraniectomy. Because by taking the bone off and opening up the intracranial system, restoring the shifts and getting the midline structures back in the midline, if it's done properly, you solve the ICP problem, usually. Short of that, if your patient has got high ICP and is thrashing around like a wild banshee, sedation is the cornerstone of ICP therapy. In a patient who's got quiet level of sedation and the ICP is still up, the next step is CPP optimization, and I'll show you how that works in a minute. And if the CPP is right where you want it in the sweet spot, 60 to 80 millimeters of mercury, then we run to our old buddies, osmotherapy, bolus osmotherapy, and careful bursts of hyperventilation. So in the unit, unlike where we ran down to the ER for the unmonitored patient, in the unit, because hyperventilation in many cases does not have a sustained effect, we don't just hyperventilate everybody right away. We save it, we hold on to it, and we can bring it in bursts when we have to get through a tough period of crisis. And then traditionally, the next step in the U.S. was pentobarbital. And then in pentobarbital refractory, and then once you're on pentobarb, everyone said, prognosis is very poor. And then we started in pentobarb refractory patients doing hypothermia, because at the time, hypothermia was very new, and we were scared of it, and we didn't really know if it was okay. Well, the protocol's changed. So it's already changed, and we've now shifted it so that now hypothermia has become step number 6. So basically, once we've gone at a few rounds of bolus osmotherapy, careful hyperventilation, and at that point, if we're not going to go and do a hemicraniectomy, we're now going for mild to moderate hypothermia. And I'll show you how we do that. So let's run through the steps one more time. Step 1, right, EVD. EVD, of course, is monitoring and therapy. And it's great in that regard. The downsides are one, you can drain or monitor, but you can't do both at the same time unless you get a special ventricular drain with an ICP sensor embedded in the tip. And they do exist. I saw one out in the exhibits earlier. Also, a big debate, when you're calculating CPP in a patient with a ventric drain, when patients are head up, I advocate for leveling the mean arterial pressure transducer and the ICP both at the head level. If the patient's upright and you have the ICP level to here and the mean arterial pressure level to the heart, you can overestimate the true cerebral perfusion pressure that the brain is going to see by up to 15 millimeters of mercury, and that might make a big difference. In terms of sedative agents, neurointensivists love short-acting continuous infusion agents that you can turn off to do your interruption and get your neuro checks on morning rounds. The agents that we love, propofol, because of a rapid onset offset. It has favorable effects on ICP. We sometimes use midazolam, not as much. We may use it as an add-on, as an adjunct for somebody who's got a traumatic brain injury and at risk for alcohol withdrawal or seizures. And we use it also to minimize propofol doses in younger patients because large volume propofol infusions over long periods of time can kill patients from propofol infusion syndrome. Or we may couple the propofol to an analgesic opioid agent such as fentanyl or remifentanil. Remifentanil has very nice super fast onset and offset qualities. So a little bit about how we use sedation. CPP optimization, I want to show you an example, and I call this slide, "Look Ma, no mannitol." Like, look Ma, no hands, riding my bicycle. Here's a guy with an intracranial pressure initially about 15 to 20 millimeters of mercury. Everything's great. We see the ICP climb up to 40 millimeters of mercury, and we see a mirror image reduction in the CPP, and we say, aha, this is a plateau wave. So what I do is I make up a dopamine infusion, and we start a dopamine infusion. We get the mean arterial pressure up, we get the CPP back up to a higher level, and bang, the ICP drops like a stone. And this is an example of how you can reverse an ICP crisis through vasomotor or vasoactive medications to try and optimize the perfusion status of the brain, to optimize the ICP. And I'm raising this point because in my next talk I'm going to be talking about more sophisticated ways of optimizing the physiology, the physiologic environment of the injured brain. But it all starts with blood pressure and these types of seminal observations. So I talked about the lung protocol, and I just want to show you these examples. Now, you remember I showed you this slide before, but with multimodality monitoring, basically the most basic form is you've got your bedside monitor connected to a laptop computer. And what I've done here is I've taken this patient's intracranial pressure over 24 hours and plotted it over against the mean arterial pressure. And you see here a regression line, and below a certain mean arterial pressure level, the ICP is going up. And it looks just like this. This slide was actually designed before we had any of this kind of data to confirm it, just based on anecdotal observations. But, you know, the physiology does exist. And this is the type of imaging that we can hopefully do in the future with advanced bedside monitoring systems. But here's another example. This is a different patient, And here's his intracranial pressure plotted against his mean arterial pressure. And you see here a linear relationship, higher mean arterial pressure driving up the ICP. He's living here in the perfusion pressure breakthrough zone. So just examples that these are real physiologic states. This is data showing how we can target CPP to maintain higher brain tissue oxygen levels. And I'll show you plenty of examples of that in the next talk as well. This is an English study. This is mean PbTO2 levels over time in 2 different cohorts of TBI patients. In terms of osmotherapy, my last minute or two, we know that mannitol works through an acute dehydrating effect. So it's an osmolar intravascular load, sucks free water, right? And then it causes a secondary vasoconstriction because of the rheologic effects of the mannitol, reducing blood viscosity. And then the third component is that there's this diuresis occurs. So there's a net efflux of free water that gets peed out with the osmotically active sugar. And that's mannitol. This is the effect of repeated boluses of mannitol illustrated here on ICP. And people will say, well, how long does a bolus of mannitol last? And the answer to me is it's different for everyone. I've seen mannitol bolusing wear off after 1 hour. I've given mannitol to somebody on a plateau wave, used it to terminate a plateau wave, and the ICP remained normal throughout the remainder of the ICU stay. So I guess in that case, the mannitol lasted forever. So if you monitor the patients, you'll know how long it's lasting, and you'll know when to give more. Mannitol bolus osmotherapy, whether you're using hypertonics, and this is an example of 23.4% saline solution. It comes in a 30 milliliter vial. We call them bullets. And that's exactly how bolus osmotherapy should be used. I don't believe in writing scheduled standing orders for the nurse to give. If the patient's sick enough that you're lowering their ICP with bolus osmotherapy, as a physician, you should be in there. And you can think of yourself as that old West gunslinger with the guns. Bang, bang, bang. You can stack these hypertonic boluses. You give them as a slow IV push over about a few minutes, and then you're standing there and you can give them every 10 minutes. You can give 4 of these in a row over 40 minutes, and sometimes that's just what it's going to take to get that ICP down. So this is individualized bolus therapy, bang, given like a Western gunslinger. That's the way it should be used. Illustration here of how in poor grade subarachnoid hemorrhage patients, the 23.4%, the dose given here is actually the equivalent of about 120 milliliters. So it's a big dose, and you see this nice effect, a peak effect on ICP at 30 minutes. You see a boost in the mean arterial pressure. And so when you're trying to decide, what should I give? Do I give mannitol or do I give hypertonic saline? Hypertonic saline comes in many concentrations. 23.4. We've used up all 23.4, so now we're giving 14%. There's 10%. There's 7.5% head of starch, which I saw in this ICU yesterday on a tour. You could give, I guess, boluses of 3%, but the volumes are larger. I like the concentrated boluses, but the differentiating factor is this. If the blood pressure is low and you want to give volume resuscitation, use the hypertonic, because that's what it's going to do. It's going to load and expand the intravascular compartment. On the other hand, if the patient is fluid overloaded or has left ventricular dysfunction, CHF, avoid hypertonic like the plague. Use the diuretic. Use the mannitol osmotic diuretic. Also, obviously, mannitol can be given effectively through a large bore peripheral IV, but the hypertonic saline solutions require central access. That's why very often in the emergency department, we reach for the mannitol first. Many studies, this is just one, have compared and find that the peak effects of both of these agents occur at about 30 minutes, and there's equivalent duration, but it's highly variable. There's some suggestion that maybe you get more sustained effects with the hypertonic solutions, but they're really quite effective. I'm going to go slightly bit over because I actually am going to do an hour and a half anyway, so if that's okay with the speaker. There's this myth, though, about using 3% or 2% solutions, and I just don't believe it. And the problem with this is if you're giving a 3% solution, let's say written at 50 milliliters an hour, you're going to get a slow, gradual increase in serum sodium over 2 to 3 days. And you'll get it up. You're just throwing so much sodium chloride at the kidney that it can't get rid of it fast enough, right? But think about it. The cells in the brain are going to have 2 or 3 days to adapt to that slow increase in the tonicity of the extracellular compartment, because sodium is the main osmotically active molecule in the extracellular compartment. So what is the cell going to do if it has time to react? It's going to adapt. And there's going to be a parallel slow increase in the tonicity of the intracellular compartment. That's what cells do. So you're not really going to get a big effect on the ICP. Look at it the other way. How about hyponatremia, right? If your sodium's 118, but it happened over a month, the patients are fine. If sodium drops from 148 to 118 in just a few hours, you're dead, because all that excess water in the extracellular compartment comes flooding into the cells and swells the cells and kills the cells. So if acute hypoosmolar states, right, lead to swelling of the brain, then you want to create acute hyperosmotic gradients to get maximal dehydrating effects on the brain. And that's why bolus osmotherapy is the way to go. On top of that, we were able to show with 3% infusion, this is sodium levels. You see here, it takes 3 days to get the sodium level up in a population of subarachnoid patients when we used to use the 3%. But we got a huge increase in pulmonary complications, much more pulmonary edema, more congestive heart failure, 5 times the amount of cardiac arrhythmias. We were volume overloading these elderly patients, these patients with left ventricular dysfunction. Hypothermia, I really just want to say, because you've heard a lot about it, these TBI studies that Case Palderman talked about where they show that the hypothermia doesn't help. Well, it's my talk, so I want to just say it may also be that most of the disability in traumatic brain injury is from axonal shearing injury, and that axonal shearing injury simply is not a temperature modifiable process. But the fact remains that all those studies showed that cooling lowers ICP. Cooling lowers intracranial pressure. And here's a very nice review article from Neurocritical Care showing that when you look at the average reduction in ICP, it's really comparable to mannitol therapy and hyperventilation, hypertonic saline bolus therapy as well. But you can give it more sustained. Now, the concept that we use, we borrowed from this very ancient paper from 1998 from Japan, and they said, you know what you should do is you just titrate the amount of hypothermia to the ICP. And so what they're showing here, they're titrating the cooling. They're able, and this is, again, in barbiturate refractory ICP, because in those days we were all cooling as the ultimate last ditch. But basically, they showed mean ICP reduction. So what we do now is we go for an initial target of 35.5 centigrade, and then if we're still losing the ICP battle, then we go down to 33. And then finally, where's my slide? I want to find you that slide. Yeah. So we made another change in our ICP protocol here. Right, I showed you the revised, and now we have the re-revised, and we've eliminated pentobarbital. I basically hate pentobarbital. I think that it kills patients because it leads to an extra month in coma, and there's a lot of baggage with the prolonged immobilization and various other kinds of effects, accelerated neuromyopathy and the like. So with that, I'm going to quit my talk. So I got to figure out how to get out of here.